Hi, I'm Dr. Luz Bonasher. I'm the president of the American College of Allergy, Asthma, and Immunology and professor of medicine in NYU Long Island School of Medicine. Today, we will talk about meeting the challenges of severe atopic dermatitis. These are my disclosures. Research grants are given to NYU Long Island Hospital, and I'm in the advisory board. Our objectives for today is to identify the challenges in patients with severe atopic dermatitis, discuss current solutions using standard of care, and discuss new and emerging treatment of atopic dermatitis. But first, let's look at the pathophysiology of atopic dermatitis. The first is that there are barrier defects, which includes a filaggrin defect and an itch scratch cycle. Irritants, allergens, infections interface with the Langerhans cells and dendritic cells, and this leads to immune activation, particularly of the Th2 and the Th22 signaling pathways. These Th2 cytokines, such as IL-4, IL-13, and IL-5, all lead to IgE class switching or induce peripheral eosinophils and mast cells. Th2 and Th22 cytokines also contribute to the impaired expression of barrier proteins and barrier impairment. One of the first challenges in atopic dermatitis is the right diagnosis. There are essential, important, and associated features defining atopic dermatitis. Essential criteria must be present. The lesion must be pruritic. You have an eczema, which can be acute, subacute, or chronic, and certain morphologies such as age-specific patterns in infants and children, which involves the face, the neck, and the extensor. In other age groups, you have flexural lesions and sparing of the groin and axillary area. Also, the history should be chronic or relapsing. Important criteria supports the diagnosis. It's usually an early age of onset and the presence of atopy, either a personal and/or family history or an elevated total or specific IgE. There is also cirrhosis or dryness. Associated criteria are not specific, but they do support the diagnosis as well. This includes atypical vascular responses, the presence of keratosis pilaris, ocular periorbital lesions, and perifollicular accentuation. Right here below, you can see lichen simplex chronicus and prurigo nodularis. There are clinical features in darker skin that make it more difficult to diagnose and treat. Erythema may be difficult to see. There's follicular accentuations, which is more common, presence of hypopigmentation, and some grayish-white skin discoloration or ashy skin. Let's look at more specific examples, such as this. You can see here in the white skin how erythema is very pronounced in this patient. However, in this darker skin, you see more of violaceous discoloration rather than redness. Also, hypopigmentation in whiter skin is less pronounced. As you go down to brown skin and then to dark skin, you will see how cosmetically disfiguring hypopigmentation is in black skin. As I said, follicular accentuation is more common in darker skin, such as in this patient, and you also end up with some grayish white skin or ashy appearance of the skin. In dark skin, there is more profound cirrhosis or dryness and lichenification. There's also a higher rate of lesions in the trunk, which makes assessing the body surface area challenging. This is prurigo nodularis, which is also more common in darker skin. As well, it is difficult to monitor topical corticosteroid side effects. Here you see telangiectasia, striae, and atrophy very prominent in white skin. However, in darker skin, this becomes less obvious. One other challenge in severe atopic dermatitis is determining the severity of the disease. The extent of lesion is more than 10% body surface area is moderate to severe atopic dermatitis. Severity of the actual lesions, which includes excoriations, lichenification, and infection, And the areas involved, such as the visible area of the face or important for function, such as the neck, genitals, palms, and soles, increases the severity of atopic dermatitis. There is a lot of symptom burden and quality of life issues, which includes pruritus, sleep quality, emotional and mental disturbance, and interference with daily activity. So, when all of the pieces of the puzzle are in place, your diagnosis is correct, you have ruled out hypersensitivity, you've controlled secondary skin infections, you've investigated food and aero allergens, education and compliance have been reinforced, and psychosocial issues has been sorted out and addressed, and your patient is still miserable. This is what we call failure. And the definition of failure includes inadequate clinical improvement, the lack of stable long-term control, meaning you continue to have flares, no relief from impairment such as pruritus, pain, loss of sleep, or poor quality of life, and unacceptable adverse events, including treatment discontinuation. When is it time to say that your treatment has failed? Unfortunately, there's no generalizable time to demonstrate efficacy of topical treatment. Given the range of potency and dosage forms of topical corticosteroids, the recommendation is up to 4 weeks of active treatment, but in selected patients and specific body sites, treatment of more than 4 weeks may be necessary. This is the American College of Allergy, Asthma, and Immunology yardstick in the treatment of atopic dermatitis. Mild to moderate atopic dermatitis need moisturization. And if there are problems with the treatment, you will then step up therapy from mild to moderate atopic dermatitis by increasing topical corticosteroid dose or potency, adding topical calcineurin inhibitors, adding crisaborole, and reevaluating the patient usually after 4 to 8 weeks. If the patient is still symptomatic in spite of your primary treatment, then you go into secondary treatment such as dupilumab, phototherapy, systemic immunosuppressant therapy such as cyclosporin, methotrexate, mycophenolate, and azathioprine, and reevaluate the patient again every 4 to 8 weeks. At this point, we recommend that the patient be seen by a specialist to consider wet wrap therapy, hospitalization, and for infants to look at comorbidities such as food allergies and environmental allergies as well. So let's go back into the pathophysiology and atopic dermatitis and look at the first drug, which is a dual anti-IL-4 IL-13 medication called dupilumab, which targets IL-4 and IL-13. So dupilumab is a fully human monoclonal antibody against IL-4 receptor alpha. This is a component of IL-4 and IL-13 receptors and approved for moderate to severe atopic dermatitis for 6 years and older. What does IL-4 and IL-13 do in atopic dermatitis? Well, it amplifies signaling of the Th2 cytokines, it increases recruitment of inflammatory cells, it increases sensitivity to allergens, and there's inappropriate IgE switching. All of this will weaken your epidermal barrier function, decrease antimicrobial proteins, decrease keratinocyte differentiation, and decrease epidermal lipids. Other systemic therapies include phototherapy or narrowband UVB and systemic immunosuppressants, but these are not approved in the United States for atopic dermatitis. Even if it shows efficacy, it does have limitations because of the risk of side effects. Cyclosporin, methotrexate, azathioprine, and mycophenolate all have black box warning for malignancies, and many will need regular follow-up and blood tests for monitoring. But what are the other newer therapies? But first, let me distinguish for you what a biologic agent is as against a small molecule. A biologic agent is produced from living organisms. They are larger in size and typically parenteral or injected. The mechanisms by which biologics interfere with the pathophysiologic pathways include soluble receptors, antibodies against the cytokines themselves, or antibodies against the cytokine receptors. The small molecules, are compounds manufactured through chemical synthesis. Most of our drugs are small molecules. They are smaller in size and may be given orally. So let's look at emerging targeted systemic treatments for atopic dermatitis in phase 2 or 3 of clinical trials. Let's look at tralokinumab and lebrikizumab. They are anti-IL-13. The phase 3 study of tralokinumab, which is a monoclonal human antibody against IL-13 in adult patients with moderate to severe atopic dermatitis, showed that 300 milligrams of tralokinumab monotherapy was superior to placebo at 16 weeks and was still tolerated up to 32 weeks. There is a higher rate of nasopharyngitis against placebo, and conjunctivitis occurred more frequently with tralokinumab than placebo. The next monoclonal antibody is IL-13. First, let's look at the mechanism of pruritus in atopic dermatitis. There is histamine-dependent and histamine-independent signaling pathways mediating pruritus in atopic dermatitis. IL-31 is believed to be critical to the development of itch in atopic dermatitis. A phase 3 trial of nemolizumab in atopic dermatitis with pruritus showed a greater reduction in pruritus than placebo plus topical agent. Let us look now at emerging targeted systemic therapies that are small molecules or JAK inhibitors. What are JAK inhibitors? Well, JAK is an intracellular signaling pathway in which many pro-inflammatory cytokines such as IL-4, IL-5, IL-13, and IL-31 elicit their pathophysiologic function. The therapeutic profile of individual JAK inhibitors depend on multiple factors. One is the relative potency towards different JAKs. The selectivity, there is a greater potency for one JAK isoform against others at a given concentration. The intracellular concentration. Note that there is no JAK inhibitor that is specific for only one JAK isoform. So what are the key cytokines in atopic dermatitis that signal through different JAK pairs that include JAK1? As you see in this diagram, IL-4, IL-4, IL-13, IL-31, TSLP, and IL-33. There are oral JAK inhibitors, baricitinib, upadacitinib, and abrocitinib. There are also topical JAK inhibitors, ruxolitinib, degocitinib, and tofacitinib. So these are the oral JAK inhibitors in phase 3. The similarities in all the studies are that they are all done in adults with moderate to severe atopic dermatitis, meaning that the atopic dermatitis involvement is over 10% of the body surface area, an EASI score of more than 12, a SCORAD of more than 25, and an IGA score of more than 3. All of the studies met primary and secondary endpoints. The variations in this study include their definition of primary and secondary endpoints, the dosing, whether topical corticosteroids is allowed or not, whether they're injectable, oral, or topical, and the duration of treatment. For topical JAKs, we have 2 topical JAKs that are studied for mild to moderate atopic dermatitis. That's ruluxitinib and tofacitinib. Ruluxitinib is a cream of 1.5% applied twice a day and was shown to be superior to triamcinolone cream of 0.1% twice a day. Delgocitinib is a pan-JAK inhibitor. In a Japanese study, it was looked at for moderate to severe atopic dermatitis, and there is also efficacy seen against the vehicle group. So we have looked at multiple factors that are combined to contribute to skin barrier dysfunction in atopic dermatitis. They include the genetics, environmental, immune responses, and the microbiome. Shifts in microbiome might explain temporal changes in disease activity. So, what is the microbiome? Is it a villain or a friend? What we know is atopic dermatitis flares have been associated with increase in Staph aureus and a reduction in microbial diversity. An increase in Staph aureus produces exotoxin that stimulates the immune response. It worsens epidermal barrier because of bacterial proteases and lipases. And the bleach bath is thought to decrease atopic dermatitis severity by reducing Staph aureus, increasing expression of barrier proteins, and its anti-inflammatory effect. Reduction in microbial diversity and not just an increase in Staph aureus is the focus for potential therapeutics. Therapy with commensal bacteria is the basis for fecal transplant in C. difficile and probably the basis also of our hygiene hypothesis. Numerous studies using topical commensal organisms to control pathogenic staph overgrowth, biofilm formation, or both are being done. Let me give you an example. This is topical microbiome transplant of Roseomonas mucosa. As we know, Roseomonas mucosa is the predominant gram-negative bacterium on the skin. 70% of healthy skin are colonized with Roseomonas mucosa, whereas only 20% of those with eczema. So 10 adults and 5 children were sprayed with Roseomonas mucosa as against sugar water for twice a week for 6 to 16 weeks. As you will see here, is an improvement of 65% of the skin that was sprayed with the Roseomonas mucosa, and there's no complication or infections noted. A more recent study showed autologous bacteriotherapy to treat Staph aureus in atopic dermatitis. We know atopic dermatitis can negatively be affected by Staph aureus. And the atopic dermatitis skin is actually deficient in antimicrobial producing coagulase negative staph that kills Staph aureus. So this is a double-blind, vehicle-controlled, randomized clinical trials where an autologous con-NS was isolated from non-lesional skin of patients, expanded by culture, and then reapplied topically to the forearm of the same patient. So they receive either the autologous con-NS or the vehicle. Staph aureus colonization on the lesional skin at the end of treatment with autologous con-NS was reduced by 99.2% as against the vehicle. This persisted for 4 days after treatment. Interestingly is that the local EASI score at day 11 on the actively treated patients were significantly improved against the vehicle. The data suggests that bacteriotherapy with an autologous strain of skin commensal bacteria can safely decrease Staph aureus colonization and improve skin severity. So I presented emerging new therapies that have the potential to revolutionize atopic dermatitis care. Your biggest challenge is that the extent of their effect on patient care will depend on their affordability and accessibility to patients from a broad range of socioeconomic groups and different insurance status. Again, thank you very much for allowing the college to participate in the APAACI annual meeting. Thank you.
Hello, my name is Anna Nowak-Węgrzyn. I am professor of pediatrics at the New York University Grossman School of Medicine and chief of Division of Pediatric Allergy and Immunology at the Hassenfeld Children's Hospital at NYU Langone Medical Center. It is my great pleasure to have the opportunity to give this presentation on the changing landscape of severe food allergies across the lifespan for the Asia Pacific Association of Allergy, Asthma, and Clinical Immunology. I thank the organizers for this, for their invitation, and I'm really thrilled to be a part of your meeting. Here are my disclosures relevant for the past 24 months, and none of them are pertinent for the content of my presentation. So I have 2 learning objectives. One is to tell you about the epidemiology of food allergy in both children and adults, and to define severe food allergy. So I think that we should start from the food allergy as an immune-mediated adverse food reaction. And just to remind you that although we frequently think about severe food allergy in terms of IgE-mediated allergy, and particularly anaphylaxis, other forms of mixed or non-IgE-mediated food allergic disorders can also be quite severe. I'm talking here about eosinophilic esophagitis or particularly food protein-induced enterocolitis syndrome. So severity is not only determined by the IgE mechanism. I think it's important for this talk to discuss epidemiology of food allergy, and we have most information about the IgE-mediated food allergy. And in infants, we've known this for many years. The most common food allergens are cow's milk, egg white, peanut, as well as tree nuts, also fish, shellfish, sesame, wheat, and soy. This is actually data from the Health Net study in Australia. And many of the childhood food allergies, such as cow's milk, egg, wheat, and soy, are being outgrown. So they resolve spontaneously during childhood. But the new survey, which has been done in the United States, shows that there could be more to it. So this was a survey, it was a population-based study which elicited parent proxy responses for 38,000 children. And the estimated current food allergy prevalence in the US was 7.6%, with a 95% confidence interval between 7.1 and 8.1. And this was excluding 4% of children whose parents reported food allergic reaction that was inconsistent with IG-mediated allergy. So non-IG-mediated food allergies were excluded. The most prevalent allergens in childhood were peanut, milk, followed by shellfish and tree nuts. And in terms of the severity of the childhood food allergy, 42% reported one or more severe food allergy, and close to 40% reported multiple food allergy. 19% reported more than one food allergy related emergency department visit in the previous year. So it was really recent. So there's no recall bias. 42% reported one or more lifetime food allergy related emergency department visit. And 40.7% had a current epinephrine autoinjector prescription. And among children, prevalence rates were higher among African American children and children with other atopic comorbidities. So, so this study sort of confirmed our knowledge and provided more information regarding multiple food allergies and severe allergies. But the same investigator group, under the direction of Ruchi Gupta, also investigated prevalence of specific food allergies among US adults. It was a cross-sectional study. Again, surveys were administered via internet and telephone. A large number of over 40,000 US adults participated. And the main outcome, similar to the study in children, were self-reported food allergies that were considered convincing if symptoms to specific allergens were consistent with IG-mediated reactions, so occurred within minutes to hours, and had the features of acute allergic reactions. And what was surprising in that survey, and I just want to draw your attention to it, is that 19% of the participants believed that they had food allergy, but 10.8% reported physician diagnosed immediate symptoms, so 10.8%. Which is equivalent of more than about 26 million of the individuals in the US. The most common individual food allergy were shellfish, followed by shrimp, then interestingly, but by cow's milk, then peanut, tree nuts, no surprise here, finfish, but then wheat and egg. So just those are the food allergies that are supposed to be outgrown with age. So that has been an interesting twist, and definitely something that should be investigated further, suggesting that either there's more persistent of allergy from the childhood, or this is a new onset of allergy in those individuals. So about 50% of food allergic adults had at least one adult onset allergy, and 38% reported at least one food allergy related emergency department visit in their lifetime. And when it comes to the overall age-specific prevalence of food allergies among US adults, they were more common in Black, Hispanic, as well as Asian racial ethnic groups compared to Caucasians. They are more common in females, and they're most common in the age group between 30 and 39 years. Also more common in the lower income groups. And obviously there's higher prevalence of food allergy reported in those that had asthma, eczema, latex allergy, venom allergy, medication allergy, urticaria, allergic rhinitis. So I think that this is really an interesting study that shows that IG-mediated food allergies are potentially on the increase among adults, at least in the United States. But I also want to discuss the severe food allergy that is non-IgE mediated, and in particular food protein-induced enterocolitis syndrome. So this was a study which we did in collaboration with Ruchi Gupta. In the survey, there was a question about FPIES and has your child ever been diagnosed by a physician, or have you or your child been diagnosed by a physician with food protein-induced enterocolitis syndrome? Now, this is a very specific and rare condition. So the questions about the presence of other chronic atopic comorbidities utilize the same questions then, and it yielded the estimate of 0.51% with a pretty narrow 95% confidence interval in children. And those children had high rates of other allergic conditions, including IG-mediated food allergy, eosinophilic esophagitis, asthma, as well as seasonal allergies. But also in that survey, the questions were collected from the adults, and to our surprise, 0.22% of US adult population reported FPIES. So this is close to 500,000 and altogether of adults, and close to a million of all Americans of all ages reported being affected by FPIES. And we know that FPIES is potentially very severe. It's an allergic emergency. So again, suggesting that even though we don't have previous prevalence estimates, this is the first study that looked into the prevalence of FPIES in the US in all age groups. Historically, FPIES has been considered as a very extremely rare food allergy, but these results suggest that it's no longer as uncommon as we believed in the past. We're talking about severe food allergy. So, how do we define severe food allergy? And I want to draw your attention to different aspects or dimensions of food allergy severity, because severe food allergy might be considered in the context of the risk for severe reaction, severe meaning life-threatening, um, but also in terms of the impact on nutrition and growth, as well as in terms of how many different food allergens are being eliminated from the diet, as well as a non-physical but social, psychological, and financial impact, as well as a quality of life. So it's definitely multidimensional aspect of severity. And let's talk about anaphylaxis. So anaphylaxis is admittedly the most potentially dangerous, potentially life-threatening, and even fatal allergic emergency. And I think the best definition of anaphylaxis is the World Health WHO definition and amended criteria for the diagnosis. Actually, sorry, this is the word allergy definition and the criteria for the diagnosis. So anaphylaxis is highly likely when any one of the following two criteria are fulfilled, such as acute onset of an illness within minutes to several hours with involvement of the skin, mucosal tissue, or both, and at least one of the following: respiratory symptoms, reduced blood pressure, or associated symptoms of end organ dysfunction, or severe gastrointestinal symptoms such as severe crampy abdominal pain or repetitive vomiting, especially after exposure to non-food allergens. Or acute onset of hypotension, bronchospasm, or laryngeal involvement after exposure to a known or highly probable allergen for that patient in minutes to several hours, even in the absence of typical skin symptoms. And it's really important to mention that although skin manifestations are the most common symptom of an acute allergic reaction, in the most severe anaphylaxis, skin symptoms may appear later and minutes later after the sort of catastrophic cardiovascular or respiratory manifestations. And anaphylaxis is increasing in prevalence. So this is again data from the US, but similar data has been generated from the United Kingdom, from Canada, Australia, which shows that over a period of 2008 to 2016, and this study was sort of nationwide study, there has been a significant increase in anaphylaxis across almost all age group except for the oldest Americans. And the highest, the steepest increases were observed in the in infants and young children under 5 years of age, and those and teenagers between 15 and 17 years of age, but also quite high among those among young adults. And this is the survey from the utilization of the emergency department, and this is was based on a 20% sample of all emergency department visit, which allowed for nationally representative estimates. From the same study, it was also shown that food is the most common known identified trigger for anaphylaxis evaluated in the emergency department. And of course, unknown triggers top the list, but among foods, peanut, tree nuts, seeds, as well as crustaceans were identified most frequently. So, how do we define severity of anaphylaxis? And there are caveats to that perception of severity, as very nicely discussed by Aisling Stafford and Paul Turner. So, it depends on the stakeholders. So, the patients with allergy and their caregivers may underestimate or overestimate severity. So, parents may perceive significant skin signs such as facial angioedema as very severe. But in contrast, may think that wheezing is a manifestation of a viral wheezing illness, when in fact it may represent anaphylaxis. The emergency personnel, such as paramedics, emergency department staff, may have limited experience with allergies, which may lead to inaccurate diagnosis. And of course, sometimes reactions are resolved by the arrival at the hospital. So the local staff in the emergency room may not appreciate the potential risk of severe anaphylaxis. Family medicine practitioners and pediatricians may have limited experience of severe reactions, either resulting in undertreatment or overtreatment. Allergy specialists, on the other hand, are trained to evaluate the spectrum of allergic disease, but they often assess the severity retrospectively. They're not involved in the provision of acute care. And then also another category of stakeholders are food industry and food regulators. They have the necessity for objective risk assessment. So this is just an example of how different stakeholder groups may have a different perception of severity. And you probably know there are multiple different anaphylaxis severity scoring systems, and they're listed in the table. And you can see that some of them have 3 grades, some of them have 5 grades, and some of them have 4 grades. And essentially, these scoring systems are not really very well standardized, and they're not in great agreement. And this is again from Paul Turner's study, when there was a grading of anaphylaxis according to different grading systems. And you can see that the best agreement is when there is a high when there's a red, sort of orange color, and there's not much of that in the table. Most of the time, the different scoring systems were achieving the concordance rate of about 50 to 60%, or up to 70%. And now let's move on to FPIES. Again, the severity of reactions, and FPIES is recognized as a medical emergency because up to 50% patients may develop hypovolemic shock. Fortunately, there's no reports of fatalities from FPIES, but reactions can be really scary. And we know a lot about FPIES in children, but more recent reports highlight also the occurrence of acute FPIES in adults. And this is a study from the US where among patients reporting allergic reactions to shrimp, 21% had exclusively gastrointestinal symptoms with negative specific IgE, and majority were female. There were reported age at the onset of between 12 and 62 years, and they had multiple reactions before this diagnosis has been considered, between 2 to 6. And then 5 of the 8 patients reported reactions to 2 or more shellfish. And the most common symptom in that study was abdominal pain. So in adults, abdominal pain is the most common symptom, in contrast to children, infants, where vomiting is the number one presentation. This was followed by emesis and then by diarrhea. This is a study from Spain, which showed that described the features of FPIES acute FPIES in adolescents and adults. Again, in that study, also 88% of the patients were female and presented with median 8 reactions before diagnosis has been considered, and the median age at onset was 25 years. So the frequency of the reported symptoms, abdominal pain, again, was the most constant feature, but abdominal pain in adult FPIES is very severe, crampy, lasting for hours and starting within 1 to 4 hours, typically 2 hours after ingestion of the food. It was followed by emesis, diarrhea. Hypothermia and lethargy was also interestingly reported by the adults. And in one case, there was a loss of consciousness due to FPIES reaction. So certainly there is a need for better recognition of FPIES in adolescents and adults, because this is definitely a form of severe food allergy. So in summary, we think that, and we have data from one study, that Ig-mediated food allergy is increasing in adults, at least in the US, in the US, food protein-induced enterocolitis syndrome affects 0.22% of adult population. So it's more than 500,000 of individuals. So it's no longer a rare occurrence. And severity of food allergy has many dimensions, so it can be considered in the context of risk for acute life-threatening reactions, multiple food allergies, nutrition and growth impairment, burden on quality of life, psychological and social well-being, as well as increased financial costs. And I think it's obvious from the discussion on the grading system that there's a need for the international allergy community to adopt a universal definition of anaphylaxis, as well as severity grading scale, along with a campaign to educate all of the stakeholders. And this will definitely, it's necessary to improve the our care for the patients in multiple levels, and also it would be extremely helpful for clinical trials of therapies for food allergy, which are riddled with the inconsistencies in how adverse events, reactions are being presented and reported, and how are they being assessed in terms of the severity. So thank you very much for your attention, and I hope you're enjoying the meeting.
Hello, I'm Dana Wallace from Nova Southeastern University in Fort Lauderdale, Florida. Over the next few minutes, I would like to share with you some of the key findings from the updated U.S. guidelines on anaphylaxis using a case-based review. We'll explore the major risk factors for biphasic anaphylaxis and the evidence both for and against the use of pre-medications for biphasic and drug-induced anaphylaxis. We'll consider the factors to use in determining the observation time in the emergency department following anaphylaxis resolution, as well as looking at the impact that the definition of anaphylaxis may have on when to administer epinephrine. The lifetime prevalence of anaphylaxis has been estimated to be about 3%. However, fatal anaphylaxis is very rare, 0.5 per million persons. In children, food is the most common trigger, while in adults, we notice that to be medication and stinging insects. Indeed, adverse reactions are very common, up to 20% of hospitalized patients, but hypersensitivity reactions account for only about 10% of these reactions. Let me introduce you to Jacob, a 7-year-old child who presents to the ED after accidentally ingesting cow's milk, to which he is severely allergic. He has audible wheeze, vomiting, generalized hives, itching, borderline hypertension, and a wide pulse pressure. He denies any other allergies or asthma. 7 minutes after the first epinephrine injection, the physician reassesses Jacob, but notes only minimum improvement. He administers a second dose of epinephrine along with IV fluids and oxygen. Now, following that second injection, Jacob improves dramatically. His blood pressure is normal. He has only mild wheezing. The hives are fading, and there is no further vomiting or nausea. Does Jacob have a high risk of developing a biphasic? Should the physician administer either antihistamines or corticosteroids? How long should he keep Jacob in the ED? And should Jacob be prescribed an epinephrine auto-injector upon discharge? To answer these questions, we'll be using two documents. The first is the Anaphylaxis 2020 Practice Parameter Update, which is a grade analysis. I will also be offering a preview to the Joint Task Force Traditional Practice Parameter Anaphylaxis Update, which is currently under development by the Anaphylaxis Work Group. The work group recommends that the clinician consider biphasic anaphylaxis is highly likely when initial anaphylaxis totally resolves, there are no symptoms for that first hour, and there is repeat anaphylaxis within 48 hours without re-exposure to the allergen trigger. We estimate that biphasic reaction has a prevalence of about 6.5%. But we really don't understand why biphasic reactions occur. Suggested pathophysiology is insufficient treatment of initial anaphylaxis, or perhaps the medication is just not working. There could be secondary absorption of a food or medication allergen, maybe a late phase response, or persistent elevation of inflammatory mediators. The highest risk factor we found in the meta-analysis was receiving more than one epinephrine during initial anaphylaxis, with an effect size of an odds ratio of 4.82. But as you will see, it does have very low evidence level. The second most common risk factor would be presentation of severe initial symptoms, as we saw in Jacob. Here, the odds ratio is 2.11. There are also other outcomes that we found to be related to the biphasic anaphylaxis, such as wide pulse pressure and cutaneous symptoms, the latter likely being confounding. So the Joint Task Force recommends that the clinician consider the severity of the initial presentation of anaphylaxis and the requirement of more than one dose of epinephrine as risk factors for developing biphasic anaphylaxis, a conditional recommendation. We further recommend that an extended clinical observation be considered in patients who do present with severe anaphylaxis or require more than one dose of epinephrine. Although not part of the systemic review and meta-analysis, simulated computer models do compare the observation of 10,000 patients with resolved anaphylaxis for 1 hour compared to 6 or more hours. The negative predictive value for 1 hour would be 95%. Now, we do get a higher negative predictive value of 97.3% if we observe 6 or more hours. However, what is the cost of that prolonged observation? It would be between $62,000 and $230,000 per additional case of biphasic anaphylaxis observed. You might ask, just when would it be cost effective? If we found that the biphasic risk was as high as 17% after 1 hour, highly unlikely in that we've spoken about it being about 6.5%, or if the fatality risk could be reduced greater than 76% with a prolonged observation. And indeed, Jacob had 4 risk factors. He had severe initial anaphylaxis, He required 2 doses of epinephrine, and he had a wide pulse pressure and cutaneous symptoms. The next questions that we look at will be, should we administer antihistamines or glucocorticosteroids to prevent anaphylaxis, either in biphasic, for a chemotherapeutic infusion, radiocontrast agents, or aeroallergen rush subcutaneous immunotherapy? We know that antihistamines have a very slow onset of action, reaching plasma levels in 30 to 120 minutes. And extravascular tissue diffusion is probably up to 220 minutes. Certainly, they benefit itching and hives and flushing, but they have no effect on hypotension, bronchospasm, or gastrointestinal symptoms. And they do not vasoconstrict. We know that administration should not ever delay epinephrine being given. And whether they have a beneficial role in prevention of biphasic anaphylaxis has yet to be determined. Likewise, there is no compelling evidence that corticosteroids are a benefit in preventing biphasic anaphylaxis. While their use have been associated with a reduced length of hospital stay, they do not have any effect in preventing return visits to the ED following discharge. We don't know if there is an added benefit if you were to administer them with either epinephrine or antihistamines, but we do know they have a slow onset of action, 4 to 6 hours. So the Joint Task Force suggests against administering glucocorticoids or antihistamines as an intervention to prevent biphasic anaphylaxis. Returning to Jacob, the mother refused the diphenhydramine because it makes him very sleepy, and she's really afraid of steroids. The ED doctor really did not insist upon these drugs because he had just read our practice grade guideline. The itching and hives cleared in 20 minutes, vital signs were normal by 25 minutes, and all symptoms had resolved by 35 minutes. Due to the risk factors, Jacob is observed for a total of 6 hours following resolution and has no further symptoms. Jacob is prescribed an epinephrine autoinjector to take home, and Jacob and his mother are educated on the signs and symptoms of anaphylaxis and in when and how to use epinephrine autoinjector. He's also referred to an allergist. Now let's look at Barbara, your retired office manager, who's also a patient. She quit working last year after a serious fracture due in part to osteoporosis. She has now been diagnosed to have ovarian cancer and is starting carboplatin. Her oncologist advised pre-medication with corticosteroids and antihistamines, explaining that this is pretty much standard for all oncologists. She wants your opinion as to the risk-benefit of taking the steroid. We looked at 11 observational studies to help answer this question, and we did find a reduced odds ratio, 0.49, meaning it would be of benefit to administer pre-medication before that first injection of chemotherapeutic infusion, but a very low certainty of evidence. So we do suggest in favor of administering glucocorticoids and/or antihistamines to prevent anaphylaxis for first administration of a chemotherapeutic infusion. However, it is a conditional recommendation. Now, what about a radiocontrast reaction? Well, Bruce had generalized hives, dizziness, and hypotension following radiocontrast administered for an IVP way back in 1973. His cardiologist has ordered a coronary angiogram with contrast, indicating that it is an isoosmolar, non-ionic agent that will be used. But Bruce is reluctant to take those oral corticosteroids. What would you advise Bruce during your shared decision-making conversation? We recognize 4 categories of adverse reactions to radiocontrast media, but we'll concentrate on anaphylactic acute onset today. In 1973, we know we were using high osmolar agents. Reaction rate was between 5 and 12%, and indeed we were using pre-medication. But after 1990, with the introduction of the low or isoosmolar non-ionic contrast agents, that hypersensitivity rate fell to 0.4%, of which only 1.4% were severe. So the question is pre-medication still needed for these newer agents, even given a history of a past reaction? 6 studies looked at this question and found that indeed it did not make a benefit to administer pre-medication before re-administration of either the same or a different low or isoosmolar radiocontrast agent. In fact, there's potential for more harm due to the side effects of corticosteroids or the increased cost that would be associated if we need to observe that patient longer. Estimates suggest that the number needed to treat to prevent one fatal reaction in a high-risk patient would be 50,000 for a cost of $131 million. So we suggest against routine administering corticosteroids or antihistamines to prevent anaphylaxis when re-administering a low or isoosmolar non-ionic radiocontrast agent. Now, Karen has severe allergic rhinitis and mild asthma due to dust mites, and SCIT has been recommended. She will be starting college in about 3 months and wants to keep her visits to the college health services to a minimum. Thus, she would like to start rush immunotherapy to dust mite. Should she take an antihistamine as pre-medication? 10 studies looked at this question and did find a benefit for pre-medication either with antihistamines or steroids with a relative risk of 0.62. However, most of these studies were directed to rush immunotherapy, not to conventional aeroallergen immunotherapy. Thus, we suggest in favor of the administration of steroids and or antihistamines to prevent anaphylaxis in patients undergoing aeroallergen rush immunotherapy. I now want to turn to Michelle, a 17-year-old teenager who's allergic to tree nuts. Her parents are out of town on business, and she's spending the night with her best friend, Sue. For dinner dessert, she has a bakery cookie. It was purchased knowing that we needed to avoid nuts. 20 minutes following ingestion, she developed scattered hives on her face and upper chest and mild abdominal cramping. They try to reach the bakery, but it's closed. Within 5 minutes, she has generalized hives, but the abdominal cramping has not intensified. What should Michelle and Sue's mother do? Does Michelle have anaphylaxis? Does she meet diagnostic criteria? Should Michelle administer epinephrine? Should Sue's mother call 911? Well, the anaphylaxis definition frequently cited is either the NIAID 2006 or the WAO 2020. They are very similar. The NIAID says anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. The WAO does substitute the words systemic hypersensitivity for allergic and adds usually before rapid, taking into account that an allergen such as alpha-gal may have a delayed onset. Now, looking at diagnostic criteria, the first criteria for both NIAID and WAO is very similar. They say acute onset of illness, skin or mucosal involvement, and an additional item. The first 2 additional items for both are respiratory compromise or reduced blood pressure, but WAO does add a third, and that is severe gastrointestinal symptoms, but indicates that this is for basically a non-food allergen. Michelle does not fulfill this criteria. Now, in criteria number 2, we do notice a difference. The NIAID says 2 or more of the following after exposure to a likely allergen: skin and mucosal involvement, respiratory compromise, reduced blood pressure, and persistent GI symptoms. While the WAO says following a probable allergen, the development of one is enough, either hypertension, laryngeal involvement, or bronchospasm, but not bronchospasm due to inhaled aeroallergen or to inhaled food allergens. Michelle does not fulfill criteria 2. For criteria number 3, the WAO does not actually have a criteria 3. The NIAID says acute onset of hypotension after exposure to a known allergen. Michelle does not fulfill this criteria. So there is a difference in the criteria when comparing NIAID and WAO. Let's look at a few clinical scenarios as to how that might relate. Say you have an adult allergic to penicillin, ingest amoxicillin, developing dyspnea and persistent vomiting within 30 minutes. This would fulfill criteria number 2 of NIAID, but would not fulfill criteria for WAO. Or perhaps it's a teenager with tree nut allergy, no history of asthma, develops severe wheezing and shortness of breath after ingestion of a protein bar containing almonds. This would not meet NIAID criteria, but would meet criteria number 2 for WAO. So we come back to Michelle. Should she self-administer epinephrine without fulfilling the diagnosis for anaphylaxis? The new guideline is recommending that meeting diagnostic criteria for anaphylaxis is not required prior to the use of epinephrine. We recommend that neither the clinical decision to administer epinephrine nor the clinical response to epinephrine be used as a surrogate marker to establish a diagnosis of anaphylaxis. Well, Michelle is way ahead of us. She's already used the epinephrine, and within 5 minutes, the hives are starting to fade. Within 10 minutes, the abdominal pain has resolved. Sue cannot reach Michelle's mother and wants to call 911, knowing they will arrive very quickly. Michelle says she is really feeling fine and begs 911 not to be called. She indicates that she has another autoinjector in case she needs it. So what should Sue's mother do? Certainly, this is a controversial issue. We know that many patients, when they improve after using epinephrine, don't want to make that call to 911. Some patients may not even use epinephrine for fear they will have to go to the emergency department. We know that it is not cost effective for all of these patients to be treated in the emergency department, but many physicians fear safety and liability if they don't recommend this. So trying for a compromise statement, we recommend that the use of epinephrine does not mandate activation of emergency medical services in the patient who experiences prompt, complete, and durable response to treatment when access to additional epinephrine and medical care is readily available if needed. So you don't have to call 911 in all cases. And with that, I thank you.